It's time to welcome our speaker, Dr. Ragaram. So, Dr. Ragaram is a dual board certified internal medicine and infectious disease physician, currently serving as the chief scientific officer and an infectious disease outpatient clinician at the Norton Infectious Disease Institute. She earned her MD from the Universidade Federal de Pernambuco, Brazil, and completed her residency and fellowship in New York. Dr. Ragaram has held academic positions at the University of Louisville, where she directed a large HIV care center and initiated a PrEP program. She has authored numerous peer-reviewed articles on HIV, vaccines, and pneumonia. So, Dr. Ragaram, I will turn it over to you.
Hi, everyone. It's great to be here. This is our final talk for this series. Can you hear me okay, Julia?
Yeah.
Okay, great. I'm going to share my screen. Okay, so we'll be talking today about the general principles of HIV treatment. So let's go to the objectives. So we will be reviewing the HIV life cycle and the classes of antiretrovirals, or ART. We will be reviewing the most commonly used ART and their unique characteristics. We will discuss the updated guidelines and principles of ART therapy in treatment-naive patients, so those who have never been on treatment before, and we will review the goals of treatment and monitoring while on ART. Okay, so we're going back to this slide. We have looked at this in other talks before, but I'm going to delve a little bit deeper into the main classes of drugs that we will be discussing today. So just as a reminder, HIV virus is a retrovirus. It is a double-stranded RNA virus, and it connects to the cell, the CD4 cell, which is its preferred cell, via receptors on that CD4 cell and proteins on the surface of the HIV virus. Once this connection is made, there's almost a physical pulling in of this virus towards the host cell membrane. And that's where you have fusion of the two membranes. And now all that genetic material of the HIV virus, along with its three main enzymes, are going to be released into the host cell. Now, here you see that one strand of viral RNA. The virus now needs to make DNA, and it does that through its enzyme, reverse transcriptase. And remember, usually we have DNA and make RNA. This is backwards because it is a retrovirus, so it's doing the opposite, right? So this viral RNA now has to form a second strand of genetic material, and that's the viral DNA. That then gets pushed into the nucleus of the cell. And here is where the enzyme, HIV enzyme integrase, is going to do exactly that. It's going to kind of snip two sections here in the host DNA and integrate the viral DNA into the host DNA. And that establishes the chronic infection. And after this, the virus really takes over the cell machinery and uses the host cell machinery to make its own proteins. And that's what you see here in the translation assembly of the new baby virus. And this little virus has to bud and mature and be released, right? So today we're going to be focusing on certain classes of medications, because I want to focus on treatment-naive patients. The approach to treatment-experienced patients is very complex and individualized, so it's harder to do a talk on that. So we'll focus on treatment-naive patients for today, and I want to focus on nucleoside reverse transcriptase inhibitors. These are the NRTIs. And the non-nucleoside reverse transcriptase inhibitors, and NRTIs. We'll also be focusing on integrase inhibitors, or integrase strand transfer inhibitors. That's why the abbreviation is INSTI. And the last class we'll focus on is the protease inhibitors. So you've seen all the steps where these medications are going to block, but let's delve into a little bit more detail on how that happens. So the first one we want to talk about is the reverse transcriptase inhibitors, right? So we have nucleoside and non-nucleoside. So this is kind of a magnification of what's happening. So essentially, you know that imagine that that top row of letters is the existing viral RNA that the virus already comes with, right? So in order to make the DNA, it needs to essentially find the complementary base pairs, right, the nucleosides from the host and connect it to that first strand. So now you have two strands, and that makes viral DNA, right? Now, what does reverse transcriptase do? It essentially makes sure that these two guys stay connected between each other, right? So how do nucleoside reverse transcriptase inhibitors work? So the name tells you they're a nucleoside. So they're essentially a copy of these little letters here. So these are the nucleosides, adenosine and guanosine and cytosine and thymidine, if you remember from biology class, right? So a nucleoside reverse transcriptase inhibitor, NRTI, is essentially a fake base pair. So what happens is let's say that reverse transcriptase is holding this all together, but instead of the real thing, the drug comes along and gets connected here. So when that happens, because the drug is not the real thing, it's going to block this whole process, and these double strand of viral DNA cannot be completed. And that's how it blocks the virus from going further in its cycle. So that's how an NRTI would work. What about an NNRTI? So that's a non-nucleoside. So the name tells you it's not a nucleoside, so it's not a fake base pair. So how these guys work is they're going to connect to the reverse transcriptase itself. And when they do that, they alter the structure of that reverse transcriptase so that it can no longer coordinate this process and keep this formation going. So that's how they work. So they work at the same step, right, in the reverse transcription, but they hit the virus in two different places. So hopefully that makes sense, but that's how those two classes of drugs work. Now, if we move along to the integrase inhibitors, so essentially we talked about the integrase enzyme snipping this part to allow the viral DNA to be integrated into the host cell DNA, right? Now, this integrase enzyme has certain metals or ions as part of its structures, things that we're familiar with: calcium, magnesium, iron. So what integrase inhibitors do is they're actually going to bind to one of these components in the structure of the enzyme, and that alters its structure and function, and then it can no longer do the process of snipping this and integrating the viral DNA. So that's how they work. And I want you to remember this because it'll be important later in this talk when we talk about drug-drug interactions. Okay, so that's the integrase process. Now let's look at the protease inhibitors and how they work. So in this whole process, when the little baby virus is starting to be assembled, what happens is these proteins here that you see, they're actually very long strands or chains of proteins. So if they stay that way in these long strands, they will not be able to be packaged appropriately into the new baby virus that's coming out. So protease is the enzyme that's going to come here and clip this big long strand of protein into smaller active protein, and that's what can be put into the new baby virus. Now, you can imagine that a protease inhibitor is going to come here, stick to the protease enzyme, and alter its structure and not allow it to do that snipping part. And therefore, you don't have the appropriate size of protein to be packaged into the new baby virus. So that's how the protease inhibitors work. Okay, so that's like the delving into the mechanism of action, but that helps you understand how these drugs work and how we put them together to make a regimen for a patient. Okay. Now, this next slide is just showing you briefly things that we won't be talking about today. These are other drugs that work at different steps in the life cycle of the virus, but they're mostly used currently, at least, for salvage therapy, or for people who are already treatment experienced. So I won't be delving into these drugs, but I do want you to just have the idea that there are several other steps where we have medications available to block the HIV life cycle. All right, so now that we know that and how these drugs work, we're going to dive into the most commonly used NRTIs. Okay, so let's start with our friend tenofovir. We talked about this a little bit at the last talk. So this is the older version of tenofovir, tenofovir disoproxil fumarate, or TDF. I joked last time that old has a D and this has a D, and that's how I remember this is the older version. So this has been tried and true and used very widely as part of a full regimen of HIV medication. However, there are some issues to watch out for with this formulation of tenofovir. So it can lead to renal insufficiency, decreased bone density over the long term, right, for both of these. And also Fanconi syndrome, which is rare. This is a type of renal tubular dysfunction where you start to have urinary wasting of things that you actually need. So you're going to be urinating out your amino acids and phosphorus and glucose. And so that dysfunction can happen. It's very rare, but has been described. So these three things here are some of the adverse events to watch out for with this older formulation of tenofovir. The other thing I will say about tenofovir TDF is that it does have activity against hepatitis B. Okay, so we talked about the older formulation, which means that there is a newer formulation, right? So the newer formulation is called tenofovir alafenamide, or TAF. And this one, though it's a newer formulation, it's actually a prodrug of TDF. So that what that means is that TAF will convert into TDF, but inside the cell. So that means you're getting less systemic distribution of the drug and less systemic side effects. So the renal and bone long-term effects are going to be less than the tenofovir disoproxil, so the older formulation. And this is still active against hepatitis B. The third one I'm going to talk about is emtricitabine, and the abbreviation is FTC. And this is co-formulated with both old tenofovir and new tenofovir. So you hear me talk about F for FTC TDF and F TAF. So that's the two co-formulations. So this particular medication is pretty well tolerated. It does have activity against hepatitis B. And the structure of it is essentially a mirror image of the next drug we'll talk about, which is lamivudine. So they're very similar drugs in structure and work very similarly. And lamivudine is the last one that I will talk about. I'm sorry, the third one I will talk about. Mirror image of emtricitabine. It does not, however, come co-formulated with TDF or TAF. And it does still have activity against hepatitis B. However, you should not use it alone for hepatitis B because you can have resistance with monotherapy. And the last drug that I will talk about in this class is called abacavir. The peculiarity with abacavir is that certain people have a gene present that's called HLA-B5701. And if they do have that gene present, they're at an increased risk of having an abacavir hypersensitivity reaction. And so before you start folks on abacavir, you are supposed to check this test first. It takes about 10-ish days to come back. But without knowing that result, you shouldn't be able to use abacavir because the hypersensitivity can range from mild to severe, right? So those are the main drugs that we would talk about in this class. To be honest, today in clinical practice in the United States, the most common ones you're going to see used are the combination of FTDF and FTAF, okay? And also want to just as a shout out, this was the first drug, HIV drug to come out and be formulated was zidovudine or AZT, and it does belong to this class of drugs. However, it had a lot of side effects, and so we currently do not use AZT anymore, or at least should not be using it, except in certain situations, for a prevention of transmission of HIV from mom to baby during the delivery process. So intrapartum, you still do use AZT. And for the babies that are born of positive mothers, they do use AZT for that initial prophylaxis period. But in general, in adults, you are not going to be using AZT or stavudine or didanosine. Okay, so these are the pearls for NRTIs. So let's move along to NNRTIs and talk about some of those medications. So the first one I'll talk about is efavirenz, and this drug is teratogenic up to 6 weeks of gestation. It does increase hepatic clearance, so you have to watch out for drug-drug interactions with other things. And the unique thing about this is it can cause some neuropsychiatric adverse events. So brain fog is pretty common and bizarre dreams. And the interesting thing about bizarre dreams is that patients don't necessarily realize that it's due to the medication. They just think they're having very vivid dreams. And so it's important for people who still happen to be on this medication to ask about that, right? Sometimes if it doesn't bother the patient particularly, it's fine, but sometimes it can be bothersome and you can talk about switching around. Again, we're using less and less efavirenz these days, but a few people are still on this. The next drug I'll talk about is nevirapine. Again, not used in adults today, does have a liver toxicity warning to it. It can be used in babies born to positive moms for prophylaxis, depending on the clinical scenario. The third one I will talk about is rilpivirine. This is a newer generation NNRTI. It does have more tolerable adverse events than efavirenz, so the percentage of the brain fog and those bizarre dreams is going to be less. Now, this particular medication does require you to eat at least 400 to 500 calories with it for appropriate absorption. You can't just get by with a granola bar or anything like that. It has to be a pretty decent meal or the regimen will fail. It will not be absorbed. And the other thing to remember is this particular medication does interact with your proton pump inhibitors, so your PPIs, your omeprazole and such, that people do get over the counter. It will decrease the absorption of drugs. So always, always ask your patients what they're taking over the counter. Very important. Now, the even newer generation of NNRTIs includes doravirine. It does survive some of the most common resistance patterns that will affect the other three we already talked about. And it's considered to be a fairly potent medication. And etravirine is also considered a newer generation. It does survive some of those more common NNRTI mutations, but it is given twice a day. So just keep that in mind. I always think of NNRTIs as like the potentially rashy and potential liver toxicity class of drugs. So these are the 5 I'll talk about. Honestly, today for a new patient, none of these are indicated as first line, but it's important to know that this class of drugs is there and that if you need to, you can use those as part of a regimen. So now let's move on to the protease inhibitors, the PIs. Now, there's several drugs in this class. I will only talk about 2. And honestly, today, there's only one that's more commonly used, and that is darunavir. This particular class of drugs is important because they're much less prone to having resistance develop. So they're very potent and durable. And for darunavir, it is a once daily medication, except in pregnancy where you have to increase that dose. The second drug I'll talk about is atazanavir, and I'm sorry that my arrow revealed the other boxes, but the second one in this class is atazanavir. Again, we have not been using this as much. It can cause this benign indirect increase in your bilirubin, and so you'll have patients come in that are on it and have slightly yellow sclera, and that's due to this effect. If it's cosmetic only, if the patient isn't bothered, you could potentially continue it, but you know then that the patient's actually taking the medication, right? This is once daily dosing even in pregnancy. It does have drug-drug interactions with proton pump inhibitors as well, can decrease the absorption of this drug, so be mindful of that. And it can cause kidney stones. So, and this is because this gets excreted renally, and it can lead to crystal formation from the drug itself. So if you are able to analyze that stone, you will find drug in it. And darunavir seems to do that to a much lesser degree. So those are the two main ones that are used today. Now, these guys come with a few side effects. So significant GI side effects to the point where tolerance is an issue and people aren't able to take it or keep up with it. So, but the issue is that these are pretty durable drugs, right? So they're a good option in some cases. And so folks started thinking, well, how can we minimize these GI side effects? How can we potentially use a smaller dose that's better tolerated, has less GI side effects, and maybe stays a little bit longer in the system, and that way I can use a smaller dose. So how can we go about doing this? So with that thought, we know that PIs are metabolized in the liver. They're broken down in the liver by the CYP3A4 system of enzymes, right? And so the thought process was, can we block that, that breakdown of the drug? That way it'll stay around longer. We can use a smaller dose that's better tolerated. So let's find a drug that blocks this, and that's called boosting. But if you're going to block the clearance of these drugs, you will also block the clearance of other drugs that use this pathway, right? So you have to watch out for drug-drug interactions. So with this thought process, it was seen that ritonavir, which is a PI, it does exactly that. It blocks that clearance. So they're like, why not combine this with a small dose of ritonavir with a smaller dose of darunavir and see if that works? And it did. However, ritonavir is notorious for causing diarrhea, and it is not available in a single tablet combination along with the darunavir, right? Or with the atazanavir, right? But back in the day, that's what was used for this boosting effect that we just walked through. And in more recent years, there is a newer booster called cobicistat. This one is not a PI at all. It has no HIV activity, but it does lead to less diarrhea and less GI intolerance. And it does come in a single tablet combination with both atazanavir and darunavir. And so you are able to reduce pill burden. So these are the pearls for the PIs. So and some of these older drugs we do not use any longer. So let's go on to the integrase inhibitors and pearls for those. So this class of drugs was truly revolutionary when they came out. The first integrase to come out was raltegravir in 2007, and you were seeing these drastic reductions in viral load that was pretty neat to see at that time. I still remember my first patient as a fellow that got put on raltegravir, and that dramatic decrease of viral load was just amazing to see. So this was the first drug to come out. Unfortunately, in today's world, the name of the game is once a day dosing, right? The less pills you have, the better. This one, unfortunately, the traditional dosing is twice a day. There is a high dose version, but you still have to take 2 pills together daily. This is quite a clean drug, very few drug interactions. There's good data in pregnancy. Unfortunately, the high dose with the 2 pills daily is not approved for pregnancy. So that was the very first integrase inhibitor to come out. The second one to come out was elvitegravir. Now, this one, it was being metabolized very quickly when it came out. So they're like, well, what can we do to keep it around longer? And we just walked through the whole process of boosting. And so they used that same principle and paired it with the cobicistat simply to allow it to stay longer in the bloodstream and be active. This one does come in a fixed dose combination, so single tablet with both FTAF and FTDF. Watch out for drug-drug interactions because of that boosting agent, the cobicistat. And this one, unfortunately, there are lower drug levels during second and third trimester of pregnancy, so you can't use it in pregnancy. So let's look at some of the newer generation integrase inhibitors. So dolutegravir is one of those. It does survive some of the mutations that would knock out the other two we just talked about. And it is available in fixed dose combination, but with abacavir and lamivudine, right? So it's available in a 1 pill once a day, but with the different backbone that than what we're used to. And it's also available by itself, though. So you can potentially combine it with FTDF or FTAF. Okay, so that's dolutegravir. And the latest kid on the block is cabotegravir. And this is available as oral and long-acting injectable. However, the oral was really only used for oral lead-in preceding the start of the injectable long-acting. And it is given as a part of a long-acting regimen along with rilpivirine, which is an NNRTI that we reviewed before. And you give it, so this is a 2-drug regimen, and it's approved for either every 4-week or every 8-week dosing. But this is not part of a treatment that you would do in a brand new treatment-naive patient, okay? So those are the pearls for integrase inhibitors. So now that we kind of walk through little peculiarities of the drugs, we're going to talk about formulating a drug regimen for a treatment-naive patient, okay? So typically we use a 3-drug regimen, okay? And that's comprised of a backbone, and that backbone is 2 NRTIs and a base. The preferred base in today's guidelines is an integrase inhibitor for treatment naive, but you can also have a base with either a protease inhibitor or an NNRTI as well. Okay, so as far as backbone, what are your options? Your options are today FTDF, FTAF, and then we talked about that lamivudine abacavir, and you can do lamivudine and old tenofovir, also comes co-formulated. Okay. Now for the base, the preferred for a treatment-naive patient is going to be an integrase inhibitor. But as I mentioned before, NNRTIs and boosted PIs are also options. And you may ask, well, why did we come up with this formula of 3 drugs? So this was trial and error, and this was as drugs for HIV were developed, you were starting to try them. With this trial and error, we saw that just using 1 drug alone was not enough to block the virus and keep it under control. Using 2 drugs from the same class was not enough. And so that's how this combination came about, right? Studies and trial and error, and finally it settled on 2 NRTIs plus a base should be able to keep that virus under control. Now, as we evolved with drug development and cleaner, newer drugs are starting to come out, there is consideration of maybe can we use just 2 drugs to treat this? And there's 1 2-drug combination that's approved for treatment-naive patients, and that's dolutegravir with lamivudine, okay? So again, I will be focusing today on treatment-naive patients, all right? Okay, so let's move on and see what are the indications and what are the Department of Health and Human Services guidelines for first choice in therapy. So I tried to simplify this as much as I could. So essentially you see here 2 groups of things. One is for those who have never used cabotegravir injections as PrEP. And what's the concern here? There is some concern that those folks might have, since they've been exposed to cabotegravir, which is an integrase inhibitor, that they could potentially have developed resistance, particularly if they weren't taking it as prescribed or they were missing doses, right? So if that's the case, you are going to have to be sure that you have a good combination of medications that that are able to be used. So if they never used cabotegravir before as PrEP, that concern with resistance is not there. Therefore, you can have an integrase as part of your base for all these regimens that you see here. Now, say you were exposed to cabotegravir, the concern for resistance to an integrase is there. Therefore, you're going to try a regimen that uses a protease instead as a base. Okay, so let's walk through these first 6 regimens here. So 2 names you need to know: bictegravir integrase and dolutegravir. If you know these 2, you know half of all the first-line regimens that are recommended. Second thing you have to know FTDF and FTAF, okay? If you know those, then you're already in a really good spot. You have pretty much all the combinations now. So here you have bictegravir with FTAF. That comes in a single tablet regimen. And it's the only 3-drug regimen that's a single tablet that is approved as first line for brand new patients, okay? Now, let's look at these other regimens. What do you have here? Dolutegravir. Dolutegravir and all these other ones, right? Every single one of them has dolutegravir, and now it's paired with either FTDF or FTAF. Now, if you remember that I told you that F stands for emtricitabine, and emtricitabine and lamivudine were mirror images of each other, then you can imagine that you can just substitute that emtricitabine here from the F to a lamivudine. So if you know that, you know all the other regimens that are listed here, okay? Now you also notice that the number of pills starts to go up, right, depending on the combination. And lastly, you have that 2-drug regimen I talked about. It's the only 2-drug regimen that's approved that is recommended for treatment-naive patients. Now, because it only has 2 drugs in it, and because of findings in the studies when they were looking at this drug initially, you should not use this combination if the patient's viral load is very high. So you should use this combination if the viral load is less than 500,000. Also, do not have active hepatitis B. Why? Because only lamivudine here has activity against hepatitis B, and you can't use it as monotherapy. And if you were to stop this medication, also you could have a flare-up. So don't use it in that case, and don't use it for rapid start either, because we don't have data for that. And also, if you don't know your baseline viral load, you shouldn't jump to it. Again, approaches are individualized per patient, right? But these are the general guidelines. And lastly, for those folks who do have an exposure to an integrases PrEP before, then you have one single tablet regimen, and that's using a protease inhibitor as your base. So that's your darunavir with cobicistat plus FTAF, and this all comes in one tablet, and it's a pretty big pill. So just keep that in mind. So those are really the initial regimen options that you would have for most treatment-naive patients. Okay, so 7 things. Remember, bictegravir, dolutegravir as bases, and in the case of exposure to CAB, you have darunavir as a base. Okay, so bictegravir, dolu, FTAF, FTDF, you got it all. All right. Okay, now, if you have a concern for any of these 3 things I'm going to tell you about, then you need to explore other things. So the first thing is renal or bone disease that doesn't allow you to use TDF or TAF. Drug-drug interactions that are going to not allow you to use integrases or proteases as a base, or if you have known or suspected drug resistance, that does not allow you to use integrase or protease inhibitors as your base, right? So if you have these three things, you need to look into other options. And we're going to walk through just a few of these other options that you could consider or when not to use certain things, okay? So step one, say you need to look for something else, you're going to look at the pre-ART viral load, right? If the baseline viral load is over 100,000, you should not use anything with ropivirine because there's a high rate of virologic failure in those cases, but you can look at other options in that class. And same thing, if your viral load's above 500,000, don't use ropivirine, and also don't use your 2-drug regimen combo that we already talked about, right? So what about if you're looking for something else outside of those main regimens, you can also look at your pre-ART CD4. If your CD4 is very low, below 200, don't use ropivirine because there are increased rates of failure, but you can consider other drugs from that class, which we reviewed. If you're looking for something else again and you're trying to use abacavir, remember you need to have your HLA B5701 results. If you don't have results or if the result is positive, you cannot use abacavir, right? And then this one we already talked about, so I'm going to skip a little bit. So have they been on oral PrEP before? And perhaps were exposed to FTAF or FTDF? If that's the case, you need to usually use a 3-drug regimen in this case, okay? But you can consider a 2-drug if you have resistance testing back, just so you know. And if you remember from the first talk, that resistance testing will take about 3 weeks to come back, right? And this one is what we already talked about, so I'm going to skip that. And then you're also going to look at comorbidities, right? If you're looking for another regimen outside of those 7 things we talked about before, you're going to look at psychiatric illness. Remember, efavirenz, you can have bizarre dreams, you can have brain fog, you're probably not a good option. Osteoporosis, you're probably going to have to avoid your old tenofovir. Renal insufficiency, are they on dialysis? Are they not on dialysis? Do they have hyperlipidemia? All these things are going to guide you if you're going to have to step out of those first-line regimens, okay? I just put a list here of little things. I'm not going to go in detail on this, but there are options to be used if you have baseline chronic kidney disease, not on dialysis. Even if you're on dialysis, there are options for those who have hyperlipidemia. There's some of these classes that are more lipid friendly than others, particularly old tenofovir TDF actually lowers your lipids, whereas new tenofovir does the opposite. So you might have to make adjustments taking all this into consideration. If you have prolonged QT, then there are certain drugs that you would avoid. And last but not least is looking at special populations. Also look at drug-drug interactions with hormonal contraceptives and always check a pregnancy test prior to initiating your ART. So those are some things that you will keep in mind if you're looking at different regimens that you would need to start. And then this here is a table with some of the most common drug-drug interactions with ART. And I'm going to highlight a couple of them, and I want you to pay attention because we're going to have some practice questions at the end, okay? So we already talked about proton pump inhibitors with both ropivirine and atazanavir, that it can decrease the levels. Then there is an interaction with the boosted protease inhibitors and steroids. Because the boosting agent is going to block clearance of the steroids, those concentrations will be higher and it can be very severe and cause actually Cushing's disease. There is an interaction between boosted PIs and statins as well. Again, it's all because you're blocking clearance, right? So in that case, you can have increased level of statins, and there's certain statins that are preferred. So things like atorvastatin and rosuvastatin are preferred for that reason. And then there's some anticoagulants that have interactions. And then inside the integrase class, integrase inhibitor class, I will highlight there's an interaction between metformin, commonly used for treatment of diabetes, and dolutegravir, where you can increase the levels of metformin. Therefore, your max dose should be 1,000 milligrams a day. You have to be very careful. Sometimes your PCPs are not aware of this interaction. So you're always going to be doing a thorough review of your patient's medication list, right? The other thing I want to highlight is integrase inhibitors as a class. Remember how when I talked about the mechanism of action, I said that integrase inhibitors are going to connect to certain ions, metals, so calcium, magnesium, iron, on the integrase enzyme, and that's how they stop the integrase enzyme from working. And so you can imagine that if those medications, the integrase inhibitors, they connect to iron and magnesium and calcium, if you're taking those as supplements, they will try and connect to those too, right? Because they don't recognize that, oh, this is not connected to the HIV virus, it's floating around, I'm going to connect to it too. So that process is called chelation, and it will decrease the levels of integrase. So if someone's on these supplements, you have to counsel them to separate out the doses so that you don't have this interaction. Okay, so pay attention to the ones I highlighted so that you can answer the questions at the end. All right. And the last step is all the other factors. And I group them as other, but all of these are very important, right? So pill size and patient preference. If a patient's unable to swallow pills, they can't do big pills, this is not going to work for them, right? So you have to find a pill that is smaller and be sure that the patient's able to take it. The other thing is meal scheduling and food access. We talked about certain drugs needing to have a meal with them. So it's important to assess that. And also for general purposes, you want to know if your patient has access to these things, right? Then there's the issue of housing, roommates, fear of stigma, and ability to store medications. That's also very important because that's going to set up your patient for failure or success, right? If they're unable to get to their medication because they're afraid someone else in the house is going to see it, then that's something you have to address, right? And also always have patients repeat back to you what you're telling them. There's a wide range of literacy and learning differences, so it's important to make sure that your patient's able to understand what you're telling them. And lastly, if there are language barriers, that also has to be addressed, right? Make sure that you're able to give instructions that are appropriate, that perhaps are in that language to help mitigate some of those barriers. So all that goes together in formulating a regimen. Okay, now we talked about how the medications worked, what regimen, how you combine them to make a regimen, and what regimens we used in treatment-naive patients. So now we're going to go into HIV testing and monitoring schedule. So there's several aspects, as you can see on the slide, that we need to monitor, but I'm going to be focusing on HIV-related testing, on bone disease risk assessment, and medication toxicity monitoring. Okay, there are other things. You're going to be checking your HIV positive patients for hyperlipidemia and cardiovascular risk. You're going to look at neuropsychiatric, other opportunistic infection screening and cancer screening, but that is a lot of detail. So we'll focus on these three that I have in the purple circles there. So let's start with the HIV related testing. So here we have 4 main tests, right? So the first one, I put here HIV serology. In our first talk of this series, we talked about the HIV 1 and 2 antibody antigen combination test, which is the routine screening test. You should have one of those at baseline if you don't have documentation from your referral source, right? So all new patients, if I don't have that information available to me, I will check it to document. The other thing that we need at baseline is HIV resistance testing. This will typically be a genotype test, and we walk through that in our first lecture of the series. And you are going to check that at baseline, right? And also prior to starting ART, if ART somehow was delayed. So let's say you have new patient comes to you, you talk to them about ART, but they at that time are not ready to start or don't want to start medication, and there's a delay, then the recommendations are if they are pregnant, you should recheck that genotype testing. If they're not pregnant, it's kind of optional if you need to recheck that at the time of start, after a delay in start. Okay. The other thing that we check routinely is a CD4 count, and that should be checked at baseline and then every 3 to 6 months. And once they are stable, you technically can extend this to once a year if they're stable on ART. I will say that in clinical practice, we tend to check it at every visit, but there is this recommendation that you can extend it to once a year once the patient's stable. And HIV viral load, you obviously will check it at baseline. Then the next check is about 4 to 8 weeks after you start therapy. Then it goes to every 3 to 4 months. And then every 6 months if your patient has been suppressed with an undetectable viral load for at least a year. Okay, so that's the HIV related testing and the scheduling for those. As far as bone disease risk assessment, you should do a bone densitometry or DEXA scan at baseline in postmenopausal women and men that are 50 years or older. So that's when you do the DEXA scans. And of course, if there's abnormalities, you will then follow up and institute therapy as appropriate. And sometimes we do that just fine, and sometimes their primary care physician will take care of it. And then as far as medication toxicity monitoring, what do we check? So a complete blood count or CBC with differential at baseline, then every 3 to 6 months when we're monitoring the CD4, and every year when you're no longer following the CD4. If you're aware of how this testing is done, in order to get a CD4 count, you do have to order a CBC with differential along with it. They can't do it without the CBC. So that's one thing you're going to check. The other thing is your BUN, creatinine, AST, ALT, and total bili. So your liver function and your kidney function, right? So you check that at baseline. You check that at that first 4 to 8 weeks after regimen initiation. And after that, it's every 6 months. In a urinalysis, so here you're going to be looking for HIV, you know that HIV can affect your kidneys, and the medications can affect your kidneys. So this is kind of looking for things that shouldn't be there. So your protein in the urine, for example, is something that we screen for. So you check that at baseline. You check that after initiation of a regimen, or if you're changing a regimen. And then every 12 months, if you're on ART, every 6 months if you happen to be on TDF or TAF, but which most patients are, right? So this boils down to essentially at least every 6 months after those initial checks. Okay, now we talked about the monitoring and when to monitor and what to monitor. We're going to talk about goals of treatment now. What is your expected response to treatment? So number one, the viral load goal. So the goal is to be undetectable or detectable below limits of quantification. So essentially, it depends on the lab that you're using. So that number can be less than 20 or less than 40 copies per ml, right? That's what's considered pretty much undetectable. As far as viral suppression, so in the studies that they've done, in the literature, the definition of viral suppression is to get that viral load to less than 200 copies per ml. Of course, we prefer the undetectable because that's the lowest that you can go, but that's what's in the literature. I would say that as long as you're under that 200 mark, you're doing fairly okay. You might have to tweak things a little or ask the patient about, are you missing doses, even here and there. That's probably the most common reason for these the detectable viral load to these low levels. And then, but how long does it take to get to that undetectable, right? So what is the expected viral load response? So it is a decrease of 2 logs or more by week 2 to 4 of treatment. So that's very quick, right? And if you don't like math, I'll kind of try and put it in perspective for you. So say you start out with a viral load of 100,000. So that's a log of 5. And you, by 1 month of treatment, you want to go from a log of 5 to a log of 3, right? A decrease of 2 logs. And a log of 3 is 1,000. So you want to go from 100,000 to 1,000 by 1 month of treatment. And if you don't like math, don't worry. The report gives you the number of viral load, right? The copies per ml, so 100,000. But it also reports the log. It will tell you log is 5. So then you can then look at the report the next time and just quickly see if it's gone down by the 2 logs. Now, how long does it take for someone to be undetectable? So up to 24 weeks of treatment. So that's what, 6 months, right? So by the 6 month mark, I think I'm doing my math right. By the 6 month mark, most of your patients should be undetectable. If not, you're going to have a conversation to try and identify barriers or things that could be interacting with the medication regimen or other options that would explain that. So that's the expected viral load response. What about the CD4 response? So an increase of CD4 count by around 50 cells at that 4 to 8 week mark is expected. And then per year, you're going to gain about 50 to 100 cells. Now, I will say in clinical practice, this is quite variable. I don't think it's set in stone that everybody goes up by 50 cells by that 4 to 8 weeks. A lot of them do, some of them do more, others, their immune system just has a slower recovery. But that's the general ballpark that you expect, okay? All right. Now that we've talked through all these things, we're going to go through a few practice cases here, okay? And you can all either holler or put your answers in the chat, and we'll go through that. So this first case is a 30-year-old newly diagnosed male. Viral load's 180,000, CD4 is 300, and just as a reminder, anything 200 and above is where you want to be at the bare minimum. That means your immune system is still able to fight off infection. Anything below 200, then you have concern for opportunistic infections, right? So CBC and CMP are normal and other labs are pending. So what would be the best first line option for this patient? So this is a brand new patient, treatment naive. So let's walk through these options here. So remember how I told you the 3 bases that we use first line is dolutegravir, bictegravir, or darunavir. So here you could potentially already eliminate C, right? And Julia, let me know if folks are saying anything in the chat. I can't see that, but so you could potentially eliminate C. And then, yes, I talked about dolutegravir, but we did say that abacavir is not like first line therapy, right? So you could potentially eliminate 2 of those. So you're left with these 2, A and B, right? And so does anyone have any ideas why you would choose one over the other? And again, I don't see anything yet in the chat, but go ahead.
No, I don't see anything yet in
Okay.
the chat
Okay,
either.
so the reason is here you would say, well, you showed me that slide that had both these options as first line therapy, right? The issue is, remember, dolutegravir lamivudine is a 2-drug regimen only. And remember how we talked about some caveats about using it? Like you shouldn't use it if the viral load's above 500,000. You shouldn't use it if the person has hepatitis B, right? So you have labs pending, so you don't know those things. And therefore is why option B, which would be bictegravir plus FTAF, that was the single tablet regimen we talked about, right? For first line, that's why this would be the option you would pick, okay? So that's one example. So let's go to the next one. So this is practice case 2. You have a patient who is 25 years old, newly diagnosed female. Viral load is 550,000. CD4 is quite good at 540. CBC and CMP are normal. You do happen to have an HLA-B5701 that's negative. And then when you check other labs, you see that they do have hepatitis B, as evidenced by the positive hepatitis B viral load there and the positive surface antigen. So in this case, what will be the first line option for this patient? So let's do our elimination game, right? So first of all, two-drug regimen here, dolutegravir and lamivudine. Can you use it with a viral load that's over 500,000? No. Can you use it with hepatitis B? No. So that's a double whammy. That one is not an option. And then now when we go here to option C. So, well, let's go to option B. Can you use bictegravir and FTAF? Well, there's nothing else that I told you that precludes the use of this, right? No kidney issues. This is a young person. So yeah, that's an option. Let's look at option C, raltegravir. Was this one of the options we talked about for first line? No, I told you dolutegravir, bictegravir, or darunavir is basis. So that would not be an option, right? And then the fourth one here, I said darunavir, yeah, that's a base, but look at the booster, ritonavir, right? That was not on the recommendations, and also tenofovir, right? With this combo is not in the recommendations, so that would not be it. And then here again, we're stuck with that abacavir, which is not first line. So that would leave us with option B. So I don't expect anyone to be an expert in picking out a regimen. I just want you to get a feel for the process in what things we look at to find the best option possible for patients. Okay. All right, we'll move to the next one. So this is patient 3, 22 years old, newly diagnosed male. Viral load is 120,000. CD4 is good at 850. CBC and CMP are fine. HLA, you have results back and it's negative. No hepatitis B, no hepatitis C, not taking any medications, but has a lot of trouble swallowing pills. A lot of trouble swallowing pills, particularly big pills. So which options would work for this patient? So this question is about knowing how big your pills are, right? So if they have trouble swallowing pills, it's like, well, can you swallow 2 small pills? That's a question you can ask. And if they can, then that gives you some options. And I will say that that combination of darunavir, Cobi, and FTAF is a pretty large pill. I even pointed it out when we were looking at the picture, right? Dolu, abacavir, and lamivudine, one, it's not really first-line therapy, but 2, it's also a pretty big pill. So then you're left with bictegravir and FTAF, and that's a reasonably sized pill. And then dolutegravir and FTAF, they're 2 separate pills, and they are on the smaller side. So that's why for this particular patient, the option would be both C and D, because you could take 1 pill that's small or 2 little pills. So, all right, let's move on to practice case 4. This is one of the ones I told you to pay attention when we were looking at interactions. So this is a 52-year-old treatment experienced male that's on dolutegravir and FTAF. He's suppressed, CD4 is good, recently diagnosed with diabetes, and the PCP started metformin 850 milligrams twice a day and atorvastatin 10 milligrams daily. He's also been taking some intranasal steroids over the counter for seasonal allergies and is compliant with ART. So which medication should you be concerned about due to drug-drug interaction? So is it the atorvastatin? Is it the fluticasone? Is it the metformin? Is it none of them, or is it all of them? So let me know, Julie, if anyone does a shout out in the chat.
We'll give it just a second for people to read them, but I don't see anything. Yeah.
Okay, so let's break this down. So we talked about when we're doing boosted proteases, right, that you could have drug-drug interactions with a statin, with a steroid. Now, dolutegravir is not a protease inhibitor. It's an integrase, right? Now, we did have a little thing at the bottom that talked about dolutegravir and metformin, right? So that it can increase the levels of metformin, and the max dose is 1,000 milligrams a day. So this person is on 850 twice a day, so that's above the max dose. So that would be what you would be concerned about. If I change this question and put here darunavir and cobicistat, the little booster, then you would be concerned about other things like the fluticasone inhaled steroid could be an issue, right? The statin could be an issue, although potentially not this one. So those are things that you would kind of keep in mind with these patients, okay? All right, so we come to the end. So that really the key to ART success is low pill burden, tolerability, and really patient preference, and really being able to counsel that patient on what to expect, when to take the medication, and to manage expectations, right? That initial appointment is very important to have all that integration for the patient. So the second point to make is to be aware of the most common ART drug-drug interactions, because as you can see, there are things that you can get over the counter that can interact, and it could put your regimen at risk. And lastly, shared decision-making and awareness of all the social support networks are really important to ensure adherence. HIV treatment today has become simpler, but the mainstay of treatment is that you must be compliant and able to take your medication every day. Without that, you run the risk of developing resistance. And so it's really doing everything that you can to ensure that the patient's going to be able to be successful and able to take that regimen. So that's what I had for you today. Thank you so much. And I'm going to stop here for any questions or comments. Thanks.
Thank you very much. It was fantastic. There are a couple of questions. Do many family medicine doctors prescribe these, or are they mostly only prescribed by specialty HIV clinics?
You know, I have seen a few primary care providers prescribe. It's very rare. I have in some very rural areas, I have seen that because there's not an option or the patient can't make it to a specialty clinic or center. But by and large, treatment is done by somebody who has some training or a specialty training in HIV. Like I said, the common everyday run-of-the-mill things are simple to manage, but it's all those moving parts and factors and the risk of resistance and understanding what the drug toxicity is to your patient that makes it complex, right? It's not just the medicine and taking a pill. It's all these other support systems and networks that increase the complexity of treatment.
We did have one individual, Ashley Tyndall. It looks like you raised your hand. I don't know if you had a question or if you meant to um, raise your hand or not, but if you want to put your question in the Q&A or send something in the chat. While we're figuring that out, several times you mentioned specialty situations, particularly with pregnant women and treatment. What do you suggest for OBs who are caring for patients nearing delivery who have not been regularly followed by their ID provider for their HIV treatment?
Yeah, that's also a very complex situation, right? So it depends on how close they are to delivery. In pregnancy, you know, you should do everything you can to start therapy and meet the patient where they're at, right? If they're at 30 weeks and still haven't started, you start, right? So I think it's also a consultation-based thing because pregnancy is very complicated. We talked about situations where certain medications that are single tablet won't work in pregnancy, right? The levels won't be adequate. There is a national hotline. I forget who I'm not sure if it's CDC or it's manned by I think they contract out, but there is a hotline that you can call, and I'll see if I can find the link to that. You can call and get advice on those cases, and I've used them before for other things, not necessarily pregnancy, and they've been extremely responsive, and they're very good at navigating those things too. So that's another option if you don't have access to ID specialty where you are.
Okay. I think that that is all the questions, unless I don't see anything written in here from Ashley. So I'm going to assume that the hand sometimes gets, you push a button and it ends up raising a hand. So thank you very much for this very informative education.